every year in the United States. Approximately 1,000 women die from pregnancy-related complications. That number should stun us, because most of these deaths are preventable. They don't happen because medicine can't save these women. They happen because medicine fails to recognize the danger in time. This is a story about what goes wrong inside hospitals. The clinical decisions, the missed signs, the cascading failures that turn a treatable emergency into a tragedy. Let's start with what a maternal emergency actually looks like. Severe bleeding, blood clots, infection spreading through the bloodstream, organ failure, dangerously high blood pressure. These aren't subtle symptoms. They're medical crises with clear warning signs. A woman bleeding heavily after delivery doesn't need advanced diagnostics. She needs immediate recognition and immediate action. But here's where the system breaks down. In 2017, a 26-year-old woman named Shalon Irving, an epidemiologist, a researcher who understood medicine, went to a hospital in Georgia for a routine delivery. Everything seemed normal at first. Then, 2 days after giving birth, she developed a blood clot in her leg. This is called deep vein thrombosis. It's a known complication of pregnancy and delivery. The hospital recognized it. They gave her blood thinners. The clot should have been manageable. But Shalon's symptoms continued to worsen. She developed chest pain, shortness of breath. Her heart rate climbed dangerously. These are textbook signs of a pulmonary embolism, a blood clot that has traveled to the lungs. It's life-threatening. It requires immediate intervention. What Shalon encountered instead was a series of clinical failures. Despite telling her doctors repeatedly that she was in severe pain, despite her vital signs showing clear distress, the hospital discharged her. They sent her home while a blood clot was actively circulating toward her lungs. She died 4 days later in her own bed. An autopsy confirmed what should have been obvious in the hospital: a massive pulmonary embolism. Shalon wasn't alone. This pattern repeats across hospitals nationwide. The clinical failure usually happens at one of several critical junctures. The first is recognition, the ability to identify that a woman is actually sick. Postpartum complications can look like ordinary discomfort to untrained eyes. Heavy bleeding gets normalized as just part of recovery. Chest pain gets dismissed as anxiety. Severe headaches get treated as migraines rather than signs of dangerous blood pressure elevation. A patient who seems anxious or emotional gets labeled as overreacting rather than listened to. Studies have documented that when Black women report severe pain or concerning symptoms, their reports are systematically taken less seriously than when white women report identical symptoms. This isn't opinion. It's measurable bias in clinical documentation and response. A Black woman's complaint of chest pain might be dismissed as anxiety. A white woman with the same complaint gets an EKG. The difference in response can be the difference between life and death. The second failure point is escalation. Even when a symptom is recognized, the response is often inadequate. A woman shows signs of infection, fever, elevated white blood cell count, rapid heart rate. The standard response would be to start broad-spectrum antibiotics immediately while investigating the source. But in many cases, hospitals delay antibiotics while waiting for test results. Those hours of delay matter profoundly when sepsis is developing. Sepsis doesn't announce itself. It progresses exponentially. By the time symptoms become undeniable, irreversible organ damage has often already occurred. Consider another documented case. A woman developed a fever 24 hours after delivery. Her doctors noted it but didn't treat it aggressively. They ran some tests. They waited for results. Over the next 12 hours, her condition deteriorated rapidly. Her blood pressure dropped, her oxygen levels fell, her organs began failing. When they finally started aggressive sepsis protocols, it was too late. She died of preventable sepsis because the initial infection wasn't treated like the emergency it was. The third failure is knowledge gaps among providers. Many obstetricians and delivery nurses aren't trained in recognizing early signs of life-threatening complications. Maternal mortality isn't typically emphasized in obstetric training the way it should be. Eclampsia, dangerously high blood pressure in pregnancy, kills women, yet some hospitals don't have clear protocols for recognizing and treating it. Amniotic fluid embolism is rare but fatal, and many providers wouldn't recognize it if it happened in front of them. Peripartum cardiomyopathy, heart failure triggered by pregnancy, often gets missed entirely because it masquerades as other conditions. Training variation is enormous. A woman admitted to one hospital might receive immediate ICU-level care for the same symptoms that would be overlooked at another hospital down the street. The fourth failure is communication breakdown. A laboring woman mentions chest pain. The nurse documents it. But the information doesn't reach the doctor, or it does but doesn't trigger concern. Multiple people are involved in maternal care: nurses, obstetricians, anesthesiologists, potentially ICU staff. When information doesn't flow clearly, critical details get lost. A woman's worsening vital signs don't prompt an escalation call. A lab value that should trigger alarm gets filed without action. We have to say this plainly. Women are dying from complications that modern medicine knows how to treat. They're dying because no one recognized the emergency. They're dying because recognition came too late. They're dying because the response was inadequate. They're dying because hospitals don't have reliable protocols. They're dying because some providers didn't know what to look for. None of this is inevitable. Other countries with equivalent medical technology have dramatically lower maternal mortality rates. The difference isn't in what's possible, it's in how well organized the response is, how seriously early warning signs are taken, how aggressively complications are treated. In many developed nations, maternal emergencies have standardized protocols. B-Lynch sutures for massive postpartum hemorrhage, magnesium sulfate for preeclampsia, immediate broad-spectrum antibiotics for fever after delivery, rapid escalation to ICU-level care when vital signs deteriorate. These aren't cutting-edge innovations. They're established clinical practices. The question haunting American maternal care is brutally simple. Why do some hospitals do this consistently and others don't? Why does a woman's survival depend on which hospital she's admitted to? Why, in the world's wealthiest nation with the most advanced medical technology, are preventable maternal deaths increasing rather than decreasing? The answer lies in failures of training, failures of protocol, failures of taking women's symptoms seriously enough, and failures of recognizing that pregnancy complications demand the same aggressive, immediate response we give to any medical emergency. Shalon Irving was educated, articulate, medically literate. She still couldn't get doctors to recognize she was dying. That failure reveals something profound about a system that isn't working. Not because we lack the knowledge or capability, but because we're not applying it consistently to the women who need it most.